Welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults through our content that informs, community that inspires, and courses that deliver.
Hello, welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults. I'm your host, Tali. With me is Erin, and this is the Research Says segment, where we find out what the lab has to say about our clinic. In today's episode, we'll discuss graded exposure for chronic low back pain in older adults, a pilot study. Hi, Erin.
Hey, Tali. That sounds like an awesome study to talk about. I'm pumped.
Thank you. I'm glad you're pumped. A little bit about lower back pain and a little bit about graded exposure. I think that we are definitely more aware and know more about chronic low back pain, but not as much about graded exposure and what it means. I got to work with that concept a little bit when I worked in a pain clinic, and I really loved it. And it kind of where I learned how important it is as people in our profession to put attention to kinesiophobia. It's not just like, oh, they're afraid of moving. It's something that we really need to pay attention for, because I know that a lot of clinicians always look for the golden exercise, I call it, or the golden tool. Something will fix this and this. But if, spoiler alert, there's no such thing as golden exercise. And also, if you don't acknowledge your patient as a whole and just see the back pain or the knee pain or the surgery or the impairment, you will never help them. So with low back pain, I think that we all know that low back pain in older adults, a lot of epidemiological studies suggest that the prevalence is around 30% of chronic low back pain in older adults. Physical and psychological disability due to chronic pain is related to social restrictions and also loss of function for activity of daily living. And the international guidelines concerning chronic pain in older people recommend non-pharmacological therapies, both to avoid problems with multiple medications and polypharmacy, and also to enhance the functional capacity and well-being. And people with chronic low back pain and chronic pain in general often experience fear of pain or re-injury, as well as associated avoidance behavior. And both of which are well-known risk factors for the emergence of disability.
That all sounds, I actually just took a MedBridge course it was run by Adrian Lowe, who's, I guess he's like a big pain neuroscience guy.
He's a very well-known researcher from Iowa. I've actually did his course too, face-to-face.
Oh, no way. That's cool. Yeah. I learned a lot from the MedBridge course. I would highly recommend it.
So this is what I had to say about pain and chronic pain. And now for graded exposure. There's a kind of like new old approach called greater exposure in vivo. It's based, among other things, on the works of Johan W.S. Leyen. I hope I'm saying it right. He's a PhD and full professor in the University of Leuven in Belgium, and also Maastricht in Netherlands. And he's been researching behavioral, cognitive, and motivational mechanisms leading to disability. I know that in psychology, when talking about exposure therapy, they mostly talk about two things, about greater exposure and about flooding, widely used type of therapy to treat phobias. So I want to talk about a study that was published in the Journal of Geriatric Physical Therapy in March of 2017 by Corina et al. I like the Journal of Geriatric Physical Therapy. It has 4 issues per year. The impact factor is 2.096, and it has pretty good ranking when it comes to rehabilitation journals, number 16 out of 65.
That's not bad. I didn't realize it was that highly regarded. I mean, I liked it.
So the aim of this study was to test cognitive behavioral exposure-based physical therapy program for older patients experiencing chronic low back pain in primary care setting. This study is phase 1 out of 2-phase trial of the complex intervention, and the aim was actually to test two things. Is it feasible? Is it something that even that us, the physical therapist, can do, and is it effective for the patient? So methods, the pilot study design, it's a one-factor observational study with repeated measurements. Quantitative measurements took place 1 week before and 2 weeks after the intervention.
Okay, so not a super long-term scope of a study. I guess it's a pilot study, so that makes sense.
Yeah, it's important to remember it's a pilot study. They had 16 participants. Convenience sample, very much a pilot study. Quantitative measurements were taken 1 week before and 2 weeks after the intervention, and qualitative semi-structures face-to-face interviews were conducted within 2 to 4 weeks after they completed the treatment. Participants, so they had the therapists, which were 3 experienced physical therapists. Each one had between 10 to 20 years of practice. They were recruited voluntarily and were trained by the study team. Patients were recruited by general medical practitioners from the department research network. They were screened by the physicians for study enrollment based on inclusion and exclusion criteria. And also before the intervention, they had an initial assessment by the study conductors.
Did they talk about the inclusion and exclusion criteria?
Yes, of course they do. Inclusion. If they were at least 65 years old, experienced chronic, non-specific low back pain for at least 3 months, as diagnosed by the general practitioner.
So a pretty standard definition of chronic low back pain.
Yeah. And if they perceived limitation in daily functions, and they had to be able to walk, and it's okay to walk with an aid, but they had to walk.
Okay.
The exclusion criteria were red flag pathologies such as tumor, fracture, or infection, or severe psychological disorders, or severe mental or cognitive impairment. Other comorbidities were tolerated.
All right.
There was a standardized treatment manual. Every one of the therapists underwent a seminar about it, and they also had a treatment manual that was developed by the exposure in vivo team. And the final program consisted of 12 sessions of 45 minutes over 9 weeks. So first 3 weeks, they had 2 sessions each week. The final 6 weeks, they had only 1 session per week.
Okay. So pretty standard as far as like how often a person might be seen in an outpatient setting, which I love.
Because one of the goals were, is it feasible to do by a physical therapist in outpatient, I think they mimic pretty correctly what happens in outpatient. That at first you see them about twice a week. When they get a little bit better, you just like trying to give them an independent of doing things at home with the home exercise program and pacing in their activity of daily living.
Nice.
The sessions focus on different treatment aspects. In each session, for example, session 1 was about determination of functional goals, like we do regularly in our first meeting with a patient.
Yeah.
Session 2 was establishment of fear hierarchy, like which thing you are more afraid of, which things are you less afraid of, like having this rank. I'll get a little bit into how they actually ranked it. It's kind of interesting. Patient education was session 2 through 4. Greater exposure to activity causing fear was session 3 to 11. So that was the bulk of the treatment.
So for the first whole week, they didn't do anything but talk, is what you're saying. Session 1 and session 2, right?
Talk and sometimes demonstrate, like, you know, kind of like how you do things, like, but nothing was given home as a home exercise program. And transferring to everyday life and reevaluating the fear hierarchy was session 11 and 12.
Yeah, so like reassessment and preparation for discharge.
Exactly. So very much mimicking common outpatient routine. Fear evaluation. The establishment and reevaluating of the patient fear hierarchy were done using photograph series of daily activities, German version for the elderly, or how I'm going to call it is photog.
Photog?
Yeah, photog, because German.
Yeah.
And it It consists of 50 photographs representing frequently performed daily activities such as vacuum cleaning, climbing stairs, putting socks on, etc. And the patient were instructed to observe each photograph carefully, to imagine performing the same movement, and to identify the extents that the movement shown would be harmful for their back.
How would they quantify the extent that they would think would be harmful for their back? Just like a number scale or what?
Yes, it's from 0 to 10. 0 is not harmful at all, and 10 is extremely harmful.
Still vague, but okay.
Why? What do you mean?
I guess like any of those numerical rating scales they're pretty flawed. Like something that's extremely harmful to me is not going to be extremely harmful for you.
And I know that in general you have problem with the subjective.
Yeah.
We have to remember that pain is subjective. All right, so they had to rate the hierarchy, every one of those 50 shades of pain.
Nice. That should be the title of the episode.
50 shades of pain, of fear. 50 shades of fear. So every one of those 50 slides, they had to rate between 0, non-harmful, or 10, extremely harmful. The brief educational sessions included information about difference between acute and chronic pain, the relationship between chronic pain and regular activity, and the role of pain-related fear, avoided activities, and pain memory. So I think that every physical therapist that sees someone with pain sometimes talks to a person about pain education.
Yeah.
At the beginning of the active treatment phase, the physical therapist addressed those activities associated with the medium amount of fear first.
Oh, okay. That's a clever way to design it.
And
it's reproducible, but it's still tailored to the patient.
Exactly.
Clever. I like it.
And that's why the pain hierarchy is so important to establish. Okay, and then they gradually progress to those with higher rating. Each practice activity causing fear was carefully introduced by the physical therapist, and both before and after the performance of the activity, patients rated the level and reason of fear and their level of confidence in the ability to perform the activity in the future.
I like that they had to say their reason. That's great. I'm very curious about the results.
And also one thing, both the psychologist and the psychotherapist were, besides the fact that they had those 10-hour training with the physical therapist, they were reachable by phone or email.
Cool. So if there are any questions.
Exactly. So if the physical therapist every now and then fear, I'm like, what am I doing? I'm not a psychologist. He calls a psychologist, and it doesn't make you a psychologist, but it does make you consult with a professional on things that you might not be that confident about. Outcome measures. Functional capacity was designated as the primary outcome because it appears to be an indicator of the autonomous life and relevant for the community dwelling older adults.
How'd they measure functional capacity?
It was measured by the Hanover Functional Ability Questionnaire, HFAQ. It's a frequently used instrument in assessment of back pain-related disability in German-speaking countries.
Is there an English version? I'm just in case I wanted to read it.
I think it was translated to English. It's not as widely used here.
Yeah, but as a measure of functional capacity, I just want to kind of see.
It was translated and also validated in English.
I dig it. Thank you.
No problem. The values measured are transferred into, it's kind of like how we use G codes, for example.
In the SNF, we don't have G codes anymore. We have GG codes because it can't get more confusing. Anyway.
But you know what I mean? Like there's a score and it's converted into percentage. A score below 60 are assumed to depict disability, and minimal clinical relevance difference is 12%.
Oh, nice. Okay, cool. So that metric is helpful.
And again, reliable and validated.
Sweet.
Yeah. Secondary outcomes were catastrophizing and avoidance belief, fear of falling, and pain intensity. Pain intensity was rated on the NRS, the numerical rating scale of 0 to 10.
Yeah, okay.
I don't need to explain that one. It was an average of the value of the worst the value of the current, and the average pain intensity in the past 6 months.
Okay.
You know how you ask people about their pain right now, the pain in the last 24 hours or the last week?
Yeah. Oh, yeah.
Yeah, so it's kind of like an average of that.
Nice.
Catastrophizing and avoidance belief were measured using the age-specific adapted 11 items short form of patient anxiety symptom scale, the KVSD 65 plus, validated in the German language, consists of two subscales, catastrophizing and avoidance. And there's a report on 6-point Likert scale, ranging from 0 to 5. 0 is never, 5 is always, of how frequently they have the perception of pain-related fearful thoughts, or how often they perform pain-avoiding behavioral responses. Fear of falling was measured with the Fall Efficacy Scale International, again, validated in German. In general, every time that you conduct a study in a different language, you need to make sure that your scale is also validated in this language.
Yeah, that's why I was asking about it, like, especially being unfamiliar with the scales.
For example, like DASH or the Austrian, everything needs to be validated in that language.
Right, because there's cultural clues and context and things that would be silly to ask people in other cultures.
Face-to-face interviews of patients and physical therapists. The study team developed a semi-structured interview guides for both groups. I don't want to go that much into that. Quantitative results. General practitioners recruited people during regular consultation between November 2012 and April of 2013. All participants completed the intervention.
Good work, participants.
Yeah, and participated in all the assessments, and there's no missing data, which is phenomenal.
I mean, it's 16 people, and it's a
I
pilot.
know, and still, one more thing that was taken was the depression score, because pain and fear avoidance are very much related to depression.
Yeah.
And sometimes we need to realize that we need to send our patient to take care of their depression, and that we're not going to help them alone. It's the same as, let's say, back pain and kidney problems. I know that you have a back pain, but the real pathology is your kidney problem, and that's why you're experiencing a back pain. And sometimes it's the same with depression. So I was glad that they measured that too.
Yeah, and then the close collaboration with a psychological/psychiatric counseling team, I think, was the right way to approach that. Because then, like, it's very easy. You do the screening, and then you're like, well, you got to talk to this person. I'm going to email him right now.
Yeah. There were no serious adverse events in any of the participants. On average, depression score were low except for one patient. All but 3 patients, so it's 81%, improved in functional ability.
As measured by that one outcome measure that we talked about?
Yes.
Okay.
11, which is 69% of the 16 participants, had clinical meaningful results.
Wait, I want to know about, like, the thing you were talking about with the rationale for why they were afraid of things. Is that coming?
Qualitative results, reasons for avoidance behavior. But that's, you see why it's also interesting to see the qualitative and not just the quantitative?
I mean, I was sold on that from the beginning. That's not true. I've been sold on that since we talked about it.
Reasons for avoidance behavior documented by the physical therapist before and after the performance for each activity were fear of pain, mentioned by 37% of the cases, fear of falling or dizziness, 24%, fear of injury of harmfulness, 18%, and non-specific exacerbation or loss of strength was 21%. In the interview, 14 out of the 16 patients stated they were very satisfied with the outcomes. They reported being more active despite their pain and experiencing less fear.
All right.
Yeah.
What about those last 2?
Oh, here, I'll talk about them. Disappointment in 2 patients was due to divergent expectations.
Okay.
which means this is not what I came for. One said, and I'll let you guess because I know you'll guess it. Guess what did they expect and didn't get?
I bet they expected like passive modalities.
Yes, I rather expected manual therapy, which means why didn't you massage me, yo?
Yeah, exactly.
That was patient number 15. Patient 10 said, I thought it would be something new from medicine, which I didn't quite understand.
I mean, if your physician or therapist tells you, like, do you want to be involved in this study about this technique that can help reduce pain without using medications, I could see someone thinking, like, new medicine.
Yeah, true. So yeah, they were disappointed because they didn't get what they wanted. They expected something else. That's the thing. Now to the physical therapists. What did they think? In general, they believed that the treatment could be incorporated into physical therapy practice.
Yeah, it's like they set it up to make it pretty easy.
And the physical therapist suggested some changes of the program. For example, they would like to have photographs with different seasonal activities, for example, like skiing, and proposed better incorporation of fall prevention.
In the education portion?
They just said better incorporated, not necessarily only in the educational, but in the treatment and training as well.
Okay.
They felt that the standardized program does not allow for day-to-day changes in physical restrictions.
I'm not surprised by that.
And with regards for the evaluation, they suggested a functional test that allows better observation of the actual behavior.
Ooh, look at you.
Yeah, look at us throwing some shade.
Yeah. Nice.
No, it is important.
Oh, absolutely. Like, those are the things that we look at.
Yeah.
Forever.
Like, this is nice and all, but can we have like a sit to stand or something like that?
Right, like give us that functional activity.
6-minute walk test or something.
Yeah, or SPPV.
Yeah. Anything you want to say before the discussion?
No, that was pretty clear cut. I liked it.
So overall, it shows that it's feasible and it does show improvement. And the individual results show only 3 patients, patient 10, 11, and 15 did not improve with regards to functional ability. Patient 10 had received a diagnosis of advanced osteoporosis and felt herself strained by caring for her husband who was disabled.
So there were some psychosocial factors.
Yes. Lack of success in patient number 11 is possibly due to high score of depression.
Yeah.
As measured by the geriatric depression scale. And a strong belief in biomechanical model of disease as perceived by the physical therapist during the treatment. So, when they're like, no, it's my disc, it's, they're so convinced and there's nothing you can do in order to explain to them, or it's not that there's nothing you can do, but 12 sessions, and when 2 of them are educational.
Yeah, and like with a standardized protocol, like it's not going to have everything for everyone.
And the reason for slightly worse functional ability in patient number 15 may be lack of adherence caused by different treatment expectations.
I feel like patient 15 or subject 15 was just like a cantankerous jerk, but like they're kind of framing it in that sort of way, which is kind of funny.
Yeah, I'm like, don't be patient 15, okay?
Yeah, like just be any patient but patient 15.
She really wanted just manual therapy. That's all she wanted. And maybe in a different research or a regular setting, she would be treated better, or you could explain a little bit more to her, but this is a study. And I'm glad she participated, because it does show that we need to make sure that the patient know what they're getting into.
Yeah, and there are thousands, if not hundreds of thousands of people just like that patient coming to your clinic. And it doesn't mean you're not going to give them manual therapy. If it helps, it helps. But like, yeah, in the context of a study, I can see where they wouldn't improve.
But in general, the treatment showed beneficial effects in nearly all patients, inappropriate for functionally impaired participants open to biopsychological model of pain.
Great.
And also there were supervision videos in some of the sessions where you tape the session and send it to the psychologist. Those supervision videos revealed that the presence of the physical therapist during exposure to previously avoided activities seemed to be essential in prompting new behavior.
Hooray, we're not going to be replaced by robots.
Yes, a lot of our job is giving confidence and reality check to our patients.
Yeah, something that we often do in the SNF setting, at least in the state of Washington, is home safety assessments. So like when someone has progressed through therapy and they're getting ready to go home, but they're like concerned about it, or if we're concerned about it, we'll go with them to their home and we'll make them do everything they need to do. Oftentimes it's to prove to them that they can do it or that they cannot, or it'll help guide our treatment to figure out what works. But yeah, it's fun because a lot of times you like family members are there and you have to be like, step back, like let them do it, please.
Yeah. Conclusion: exposure-based treatment applied by physical therapists in collaboration with primary care physicians and psychologists shows promising results with respect to treatment outcomes and feasibility. It seems to be suitable for older patients who have chronic pain with fear avoidance behaviors and are functionally impaired. Apart from benefits achieved by participants, the study offers practical guidance for physical therapists and also facilitates further research. On the basis of our data, investigators are encouraged to methodologically design more refined studies.
Cool study, Tali. Nice work.
I'm glad. I like looking into kinesiophobia. I think it's an interesting subject that we all need to be more familiar with.
Yeah, because everyone's got pain, you know? They usually don't come to us unless they're in pain. And often that pain has lasted a long time, so.
And also, we need to acknowledge their fear. Thank you very much for joining us. Thank you very much, Erin Carey.
Thank you for having me, Tali.
You're welcome. I'm Tali Spaceman, and this was Research Says. See you next time, or hear you next time.
Thank you for listening to the Geros Health Podcast. Go to geroshealth.com to get the show notes for this episode and find out how you can join the Geros community for free. You'll get access to our private Facebook group and the weekly Geros recap where we share our favorite reads, podcasts, and any interesting conversations in the Geros community that week. Once again, that's GEROS health.com. Thanks for listening.